Hello, and welcome to today's webinar focusing on Housing as Healthcare, an in-depth look at Denver HCH's integrated model of care. I'm Barbara DiPietro. I'm the Senior Policy Director here with the Council, and I'll be acting as the moderator for today's webinar. As you can see on this title slide, this webinar is being supported through a cooperative agreement with the Health Resources and Services Administration at HHS. Yes, this session is being recorded, and yes, the recording will be available on our website along with the slides. So I know that's a big frequently asked question, so all of this will be available. This will also be a 90-minute webinar, so we'll try to keep the bulk of our conversation to an hour and then reserve that last chunk of time for questions and answers. You will see that below the presentation slide, you should see a chat box for your questions and any technical issues you might be having. So please type your questions into that box at any time during the presentation. We'll get to as many of the content question and answers at the end, and then our technical assistant, Hannah, will answer your technical issues along the way. So I just want to repeat, yes, the PowerPoint presentation and the recording of this webinar will be posted on our website within a few working days, and even better, if you registered for this event, the link will be emailed directly to you. So that makes it very efficient. And so before I get started, I just wanted to put this discussion into context with where we are right now in the healthcare field. When I first started in this job about 10 years ago, I had an opportunity to go out to the Colorado Coalition for the Homeless. I was brand new to the HCH community. I was trying to figure out how all of this worked. And John Parvinsky was kind enough to sit down with me and talk with me about how they did things in Denver. And I walked away from that thinking, wow, those folks have got going on. And what really struck me at the time was how systematic they had made their capital housing development. And I'm not talking about one or two isolated projects, but I'm talking about like a true system of development. And they were really unique. They're still unique in what they're doing and how they integrate housing and healthcare. And so now when we fast forward 10 years later, everybody is now trying to figure out how to integrate housing and healthcare. We're seeing hospital systems, large integrated health systems, health insurers, our government partners at HUD and HHS, other HCH and other health center programs. Everyone's trying to figure out how to do this. And it's now become the hot topic. And I just want to really make it clear that Denver was ahead of the curve, and they were doing this before it really got hot. And so I just see them as true visionaries in this field. And so in that spirit, here at the Baltimore Healthcare for the Homeless program, where I'm based, we're also looking to evolve our housing work. And so in December, I joined Baltimore CEO Kevin Lindemood and some of his executive team on a trip out to CCH, where we got to ask John and his team everything we could think of about how they do it. And that trip yielded the policy brief that you'll see linked in the resources box below the presentation slides. So with that, I want to extend my thanks to Kevin at Baltimore for making that trip possible, and to John and his team for being so generous with their time and their expertise. It's truly an honor to work with an HCH family where we all share our best practices so freely. Want to just then kind of plunge in a little bit here. Obviously, I'm a solid member of the John Parvinsky fan club, the president and CEO of Colorado Coalition for the Homeless, and I'm delighted he's with us today. And now that I've gotten to spend some more time with Lisa Thompson, their Chief Operating Officer, Bill Windsor, their Chief Real Estate Officer, and Matt Malika, their Vice President of Housing Assistance, it's so wonderful to be able to learn from all of your expertise and your experience in this regard. And so I'm so glad that you've all agreed to come and do this discussion with us on this webinar today. Want to talk a little bit about just the scope that we'll go over today, but in the meantime, we want to get a better sense of who's on the phone right now. So Hannah, if you can bring up our poll, if everybody could get ready to vote. Voting is very important, and for this webinar, we will get a better sense of what roles people are filling out there in the audience. And I think for us, it's really important too. There is a role in this work for everybody. whether you're in a government partner, in development, in finance, in clinical work. All of that is just so important. And so again, trying to tease through what pieces people can really operationalize out of this discussion certainly will depend on your role and where you're sitting, but then also kind of talking about how the partnerships come together to make this feasible. We'll just go a minute more, and it looks like we've got a lot of outreach case management folks. Let's see, and then our percentages here. We have about 100 folks on the call, so we'll keep going just for a minute more and just to get a sense. So it's a pretty broad spread of a lot of different roles here. So really appreciate that. That, again, keeps the conversation very broad. Thanks, Hannah. Appreciate it. We can take down that poll. And then you'll note, too, if you've already looked at the policy brief, our discussion will roughly follow that, that agenda. We'll talk about their structure. We'll talk about how they develop financing from a portfolio perspective and financing and the process they use, how they plan and design projects, how they assess needs and align services, and what their service delivery models look like, and then how they integrate services and property management. So those are really big topics. Each one of those things could be its own hour-and-a-half discussion. So we're going to hit the highlights of a lot of these pieces, and then we'll focus on your questions at the end. And so with that, I am going to turn it over to John to get us started about Colorado Coalition. So John, take it away.
Thanks, Barbara. Glad to join you all here today. I'm going to start with a little overview of the Colorado Coalition for the Homeless. The coalition was formed in 1984. I've been at the helm here since 1985. So just about 33 years. The coalition is a little bit different than most coalitions in that early on we recognized that while advocacy was at the roots of what we were formed to do, that we basically filled niches that we saw in terms of responding to the increased homelessness in our community. And when we weren't able to find partners to fill that niche, we then figured out how to do it ourselves. And so we started as one of the original 19 grantees of the Healthcare for the Homeless program from the Robert Wood Johnson Foundation, and was then one of the original Healthcare for the Homeless HRSA grantees as well. We've grown that Healthcare for the Homeless program over the 30-plus years, so that currently we're serving about 13,500 patients a year to a little bit over 100,000 visits a year in both direct primary care, but also the ancillary services. As we have grown, we have really focused on integrated health care, so that while we started as a small primary care clinic, we soon added behavioral health, mental health care, and substance treatment services when the mental health centers and the addiction treatment centers were not able to serve the people that we were serving. We added dental pretty early on. We've been able to add a vision clinic and pharmacy as well. So currently we operate 5 clinical sites providing that integrated health care. And then we brought that care into the housing that we've developed over the years. Well, we recognized pretty early on that if we were providing quality health care to individuals and families at our clinics, and then sending them back out onto the streets or under the bridges or even into the shelters, the likelihood that their health status would improve was pretty low. And so it was very early on in our development that we started looking for housing options for our folks. And when we were not able to get the housing authorities or the nonprofit housing developers to house the people with disabilities and other special needs that we were serving, we started buying housing and then building housing. So today we have about 18 developments that we've developed over the last 25 years of about 1,800 housing units. And it really runs the gamut in terms of the various types and models that we've developed, being opportunistic in terms of looking for properties that were available, sites that were available, the funding that was available to be able to develop them, and looking at how to meet the needs, the priority needs that we were seeing both in our health centers and our other service sites. So in addition to those housing developments, and we'll talk about in a minute how we actually build them, we also operate a number of rental assistance programs funded through a variety of sources that allows us to house people both on a scattered site basis as well as to allow them to afford to live in the properties that we have developed. And that includes permanent supportive housing, rapid rehousing, project-based Section 8, as well as continuum of care funded rental assistance for both site-based and scattered site units. We have operated that primarily on a housing first basis. We are one of the early adopters of Housing First around 2000 and utilizing and expanding that practice. So in addition to that rental assistance and the housing that we own and manage, we've developed a number of different housing service initiatives, assertive community treatment, utilizing that housing first approach, as well as our residential services that provide on-site services within the buildings that we own and manage, as well as our family support services staff that provide similar services to properties that are targeted primarily to homeless families. In addition to those housing and healthcare services, we've branched out to meet some of the other needs of our homeless population, including providing addiction recovery services through a residential recovery support service program in Southeast Colorado, through vocational employment services, and also for child care and child development services for homeless families. So that's a basic overview of the coalition in terms of the number of different programs. We're funded through a variety of grants. The HRSA grant continues to be a critical piece. Colorado is a Medicaid expansion state, and so starting in 2012, we were able to increase our insured population from what had historically been about 10% to what is now around 75%. And that has provided some great flexibility to be able to expand our health services and the integrated services that we provide. In addition, HUD grants that we have received over the years to do individual developments, and more recently targeted rental assistance and service grants has really allowed us to expand our reach to house more families and individuals. So the coalition is typically the parent. We have about 25 different subsidiaries of the coalition that provide the various housing and support services. But the coalition is essentially the parent and serves as a sponsor in the development of fixed housing developments. One of our subsidiaries is the Renaissance Housing Development Corporation, and RHDC serves as a developer, basically playing that lead role in bringing together the financing resources, the property development, the construction management and oversight to be able to actually take the project from conception to construction and then finally to place it into service. And then they turn it over to our property management subsidiary, the Renaissance Property Management Corporation. And so RPMC provides that management services. They essentially act as the landlord for the families and individuals that we house, ensuring that the property is maintained, that the rents are collected, that the bills are paid, and all the other management and compliance for all the funding sources are adhered to. And then for each individual development that we do, we typically will create a housing corporation that serves as a general partner in a tax credit partnership that we create to be able to take advantage of the tax benefits of the low-income housing tax credit program. Most of our housing, not all, but most of it has been made possible through the use of the low-income housing tax credit program. And because we're a nonprofit, having low-income housing tax credits doesn't do us any good because the tax credits provide a reduction in tax liability. As a nonprofit, we don't have any federal income tax liability. So by creating a tax credit partnership with a for-profit entity, typically a bank as an investor, they are able to take advantage of the tax credits in return for the equity or the capital contribution that they make for a property, and take that over a 15-year period to get 10 years of tax credits and additional 5 years of tax write-offs, such that at the end of a 15-year period, they're able to walk away for $1 and essentially have gotten back the money that they put in initially to construct the property in return, and plus a rate of return that makes it financially viable for them to be partners. So I'm going to talk a little bit just about the leadership structure. There's a little bit more detail in the policy brief, but overall, I'm the president and CEO of the coalition, and we have an executive team that includes our chief real estate officer, who's charged with overseeing the housing development and the housing management operations, our chief operating officer, who you'll be hearing from, Lisa Thompson, who is essentially charged with overseeing all of the housing and healthcare services that the coalition provides. A chief financial officer that essentially takes care of the accounting and financial management, a chief quality and information officer that is responsible for all of our information systems and our quality assurance, a chief development officer, which is our chief fundraiser that ensures that we have flexible funding to meet a variety of our initiatives, a chief clinical officer for integrated health services, also known as a chief medical officer, who is charged with essentially ensuring clinical quality across all of our programs, both within the health center, but also within our housing services. And then we also have a newly minted chief legal officer, general legal counsel, that it brings some additional legal capacity. I have to admit that I am a recovering lawyer, and so I've been able to use those skills over the years to be able to help to structure some of these transactions, and having some additional capacity is beneficial to the organization. And then we also have a vice president of communications and public policy that basically leads the charge in our public advocacy and policy work, much of which is important in terms of ensuring that resources are available to allow us to carry out this work. To support Lisa in her work as a chief operating officer, we have a vice president of integrated health services that's responsible essentially as our project director for our health center activity. We have a vice president of housing and support services that provides the oversight of those programmatic initiatives. And Matt Malika has just joined the team as the vice president of housing assistance, charged with coordinating all of this rental assistance and housing supports with the properties that we own, as well as with scattered site housing owned by private landlords, to maximize our ability to house as many people as possible as quickly as possible. So overall, the coalition, as I mentioned, has developed about 18 different projects, about 1,800 units. As you can see in the slide, there are a variety of different types. Every type looks a little bit differently. Somewhat is developed and based on the population that we're serving, what's achievable on a particular site, as well as what the priority needs are for a particular population. Some of the properties have been mixed income or mixed use, where we have some anywhere from 25% to half of the units are targeted for homeless populations as they move off the streets and into housing, and some of which are providing 100% dedicated as housing for formerly homeless families or individuals. The integrated housing approach has allowed us to basically provide the funding and the ability to house and to develop these properties when we don't have enough rental assistance subsidies to house people coming directly off of the streets. And so one of the nice features of the integrated housing approach is that it reduces the stigma that might otherwise attach to a homeless-only facility, and it also provides a more normative social and economic integration within the property. In many of our properties, we've been able to incorporate other service uses, the health center at Stout Street that we'll talk about in more detail, a satellite clinic at our West End Health Center and lots that provides integrated health care, and some retail services that have provided both employment services for our residents and the homeless population, as well as an income stream to help support the housing activities. When we look at the financing for particular projects, one of the things that's important to note is that when you're talking about a fixed site facility, that is actually building and operating housing, there are really three different types of funding and three different areas that you need to have dedicated funding for in order to get a project off the ground and to keep it viable. First is to actually have the funding to build, to acquire a site or acquire an apartment building, and to have the funds to construct or renovate that facility. So that capital financing we'll talk about in a little bit more detail is what it costs or what you need to essentially develop the project and put it into service. But for people that we're serving who may have no income or may have very limited incomes anywhere, whether it's general assistance or Social Security or even minimum wage entry-level jobs, they don't earn enough to be able to pay what it costs to operate a facility. What we're seeing that for our permanent supportive housing projects, that the monthly operating costs for those properties average around $600 to $700 a month, depending on the level of on-site maintenance staff and security staff that's required. And so in order to pay the bills without any debt service on a property, that is that if somebody was to finance 100% of a construction project and turn the building over to us, we could not house the majority of the people that we house because they wouldn't be able to afford the $600 or $700 a month of rent that it would take to be able to service the property. And so the way that we are able to make that unit affordable to people coming off the streets or out of the shelters is to have either rental assistance for those tenants or operating subsidies that essentially pay that $600 to $700 a month. So without that rental assistance, and sometimes we'll have maybe half of the units with rental assistance, and again with that integrated approach, if we have some people who can afford to pay that $600 to $700 a month, and then the operating subsidy or rental assistance that allows a homeless individual to pay 30% of their income for rent, and the balance is made up by from funding through HUD, through either Section 8 or Continuum of Care vouchers. that allows us to serve that population. And then the third piece is financing or funding for the supportive services. That $600 to $700 a month doesn't include the social services or the support services that many of our tenants need, particularly those who are chronically homeless with high vulnerabilities. And so having dedicated funding for the services, on-site services within the housing is critical. And unless we're able to basically get dedicated funding for each of those pieces, we can't have a successful project, and we can't replicate it and have the confidence that we can do the pipeline that Barbara referred to earlier. Because if we get a project built and leased up, and then we're having to raise money year after year just to keep it going, that doesn't provide the opportunities to then build new housing, because at some point there's not enough funding out there through general fundraising activities to keep that going. So again, those three areas are critical. If you're doing scattered site housing, you can basically don't have to raise the money for the capital construction. Raising money for the rental assistance and the support services is sufficient. The trade-off, as you'll hear later, is that the scattered site housing is a little bit more difficult to manage, and the services are more disparate, so it's less efficient. And there's some benefits where a congregate location with on-site security and staffing allows you to serve a more highly vulnerable population than you might be able to do in a scattered site setting. So I just want to talk a little bit about some of the specifics. I mentioned the low-income housing tax credit program. Again, that is a critical piece. It typically funds anywhere from 60 to 80% of the cost of development of the housing. And it's based on an allocation that is made by the State Housing Finance Authority. Most states, these allocations of low-income housing tax credits, particularly the 9% competitive credits, are very competitive. Colorado just completed its round of allocations for the 9% credits this year. I believe there were about over 32 projects that were seeking those awards, and only about 8 projects were awarded funds. Fortunately, we were one of a project that was selected for a new veterans housing project near the new VA hospital in Aurora. But it is very competitive, and looking at the availability of those credits in your state is a critical piece. We've been able to also use new market tax credits and historic tax credits for some of our buildings, and that has allowed us to leverage those additional credits to be able to fund a greater degree of construction that we might otherwise have. The new market tax credits are typically not available to support actual residential housing activities, but we've used the new market credits to support the development of our health center within the Stout Street Health Center in particular. And we are looking at using the new market tax credit program to do a new standalone medical respite care facility adjacent to our Stout Street Health Center. In addition to the tax credits, we look to federal, state, and local grant sources. The HOME program, which is a HUD-funded program that is devolved or distributed to the state and to the local communities. I believe we've had home funds in every one of our developments, and so we have looked to the Colorado Division of Housing that allocates the state home funds, and when we're doing developments in Denver, the city and county of Denver to provide pass-through of their home funds into our projects. More recently, Denver has established an affordable housing fund, and we've been able to advocate to get 25% of those funds targeted for permanent supportive housing. And so that is a new source of funding that can help match the state funding to be able to add to the low-income housing tax credits. In some cases, we've been able to get foundation funding to go into the bricks and mortar. It's been interesting to see that some foundations and some large donors are more interested now in supporting the development of permanent supportive housing or affordable housing, and are more interested in putting their money into the bricks and mortar rather than the services. Other foundations are more interested in funding the services. So being able to know the lay of the land in your community to figure out how to get those funds allocated to the right activity is an important piece. And then again, on the operating side, the housing vouchers, as I mentioned, is critical because, again, if we didn't have housing vouchers or some way to stratify the income and the rent, to pay for the rents, we wouldn't be able to house people with zero income. And we are housing many people who are coming in the door with zero income, and the support services that we could provide at the property allow them to get eligible for Social Security or SSI, get on food stamps, get the other supports that they need, both to pay their rent, a portion of their rent, and to meet their other housing and living needs. And then we also get the income from the rent. When we have an integrated project, the rents from the affordable housing tenants are helping to subsidize those who may not be able to pay the full amount of rent necessary to operate the property. So those are the typical sources and stages. Again, getting the equity and bridge funds to actually buy the property and to build the property, to fund the pre-development activity, and then to actually do the construction. We typically have construction lending sources that bridge to the low-income housing tax credit equity. And so once the building is complete, the equity from the tax credit investor flows in, pays off that construction loan, and then allows us to lease up and to be able to continue to provide that permanent supportive housing or integrated housing to the folks that we serve. So now I'll turn it over to Bill Windsor, who's going to talk a little bit more about the development process.
Hi, this is Bill Windsor, Chief Real Estate Officer. Thank you, John. And I want to go over a couple of items fairly quickly. The first one is about the ideal size of a typical project. The ideal size of a project is essentially maximizing the number of units that you can develop for the funding sources you have available. So it's always a balancing act, but as John had mentioned earlier, in order to maximize efficiencies, you want to develop the maximum amount of units for the funding sources that you have. And looking at unit mixes, particularly studio versus 1- and 2-bedroom units for the homeless, generally our residents prefer to have a 1-bedroom unit over a studio unit, but I don't want to discount the fact that there is a need for studio units, especially for folks who are moving directly out of homelessness into one of our buildings. Smaller units are a little bit easier for some of our clients to manage. Likewise, with a 2-bedroom unit, we will have clients that have healthcare issues, so we always want to have at least some 2-bedroom units in a project so that we can have a live-in healthcare provider assist the client from time to time. In regards to the zoning, the most critical aspect of that is to attempt to obtain properties that you're going to develop that have the zoning by rights available already. If you need to change the zoning, you're giving yourself an opportunity for the community to protest the development of the project. So it's definitely less risky if you are obtaining properties to where you could develop by rights. And then in regards to whether you want to do rehab or new, overall, new development is the most efficient and gives you your best development opportunity for the dollar. The exception to that could be if you can find an exceptional price on an existing property that the rehab costs, which tend to be more expensive than new development costs, are such that it makes sense to go for a rehab as opposed to new development. In regards to client and staff involvement, we have found that it's absolutely essential to involve our clients and our staff into the development of the project right from the very beginning. And in order to maximize that, we've developed a process to where we have a cyclical involvement for our clients and staff. So starting, let's say, upon property acquisition, when we're starting to put pencil first down to paper for the design process, we will have our clients and staff meet. We'll conduct charrettes with the architectural team to review the design right from scratch and start outlining what works and what doesn't work. We also maintain a spreadsheet of best practices, and we give that to the architect right up front, so the architect doesn't need to guess what type of features, what type of material choices, etc., work well for us. So throughout the design process, we have feedback and design charrettes. When we go into the construction process, we also bring in our staff to meet with the general contractors, particularly towards the last third of the construction site, where we might need to be making choices on the fly for changing something within the design due to change orders, so that we have that feedback coming in. Once we're done with the development and with the construction, and we've hit our CO, we then run another charrette where we invite staff and residents to sit down with us, and we review the existing development, asking them what works and what doesn't work, in order to get the feedback and find out if there is something that we've done new and different. Does that actually work for us? Let's move to the next one, please. So we want to just take a look at some pro tips. If you are a smaller organization and if you do not have in-house property management and or program management, you very much want to start developing relationships with organizations that provide that, so that when you're moving into the development phase, you can do so in that integrated process to where both of those teams are providing feedback to you during the development process. We also need to talk about meeting with the community. Anything that deals with homelessness has a lot of misconceptions, and we always will have resistance to that. So one of the things that's very important that we do is that we meet with the community as soon as we identify the site and as soon as we acquire the property. We have found it is best to break down our community meetings to local neighborhood community groups. We don't want to invite everybody and have hundreds of people stepping into it and asking questions that we can't keep up with. So instead, what we do, we deliberately invite ourselves, we're asked to be invited to neighborhood group community meetings so that we can introduce the project and what we're doing and start asking questions. And then especially when there's a lot of community pushback to our development, we will invite that the individual neighborhood groups provide one member to be on a development advisory committee to give us feedback, and then we actually invite those people. We meet once a month. We show them what we're doing. We have the architect there, and we walk them through and say, this is what we are doing. What's your feedback on all of these different design issues? And it gives this sense of the community starts having a sense of ownership into the project. Along those lines as well, when we're done with our development and we move into the property, we also go to the neighborhood groups, and our property manager then introduces themselves to the neighborhood groups, gives them full contact information, and that lets them know that if there's ever any problems, they can meet with us and provide us feedback, and we'll work with them for making sure that the community group is involved in that. The last thing that we do that I want to bring up that's very important, we never build substandard housing. Our projects meet or exceed the market rate projects in the community. And so an important way of gaining acceptance for your projects is that we provide tours of our projects, and we invite those who object to what we're doing to walk our projects, meet with our property managers, meet with our case management team and understand what our process is, and that what we are doing here is not shelter housing by any standard and not substandard housing. These projects are as good as anything else that's out there. And that brings us over to assessing needs and aligning services.
Thanks, Bill. So this is Matt Malika, the Vice President of Housing Assistance with the Coalition. I'm going to talk a little bit about how we get referrals for our units. So John mentioned the three basic components of developing housing development, and that is raising capital, the rental assistance component, and supportive services. So we're going to focus here on this slide on the rental assistance and how we get referrals for those units. Like most of you out there in the larger communities, you're working with your coordinated entry system, and that's no different here in Denver. Mainly our referrals for these units are coming through our coordinated entry system, which is called One Home here. And that's not without its challenges, given CCH's layered funding and our ability to serve varied populations in our units. So I'm going to talk a little bit about how we get referrals and how we assign with the tenant's choice, obviously, how we assign units within our programs. So our continuum uses the VI SPDAT to assess for housing need, essentially, here. And I think, like a lot of you out there, we found that the VI SPDAT is not a great assessment tool for housing. It can measure vulnerability on the street, but not necessarily how folks will do once they're in their housing program. So there are times when we have multiple units submitted into the coordinated entry system in several developments that allow us some wiggle room to give client choice for properties when they come up. And when that happens, we're able to get a better understanding of the household and the tenant and their needs. We talk to our outreach department here at CCH. We have a wonderful outreach department here, a lot of folks who have been in the field for a long time and working at CCH for a long time, and they know our community members well. And we rely on them not only for the location of folks that are that come up for housing resources, but also as a great tool for understanding the individuals that get referred and their needs. So we'll talk to our outreach department, and we'll also talk to the folks that completed the VI SPDAT about what level of service they might need. And then we know at our disposal, we're lucky here at CCH to have varying supportive services. So as John mentioned, we have assertive community treatment teams, and those teams generally focus on the most vulnerable in our communities and provide more intensive services. And we have supportive housing units that get case management and clinical services, but mainly use our health center as a referral option. And so we, for medical and behavioral health. So we use our resources the best we can when we get a referral, and we try to match folks to our resources appropriately and keeping their choice in mind. We believe that if someone has a choice in their housing, they're more likely to be successful. So what's happened with our coordinated entry system, and one of the challenges we face, is we're getting folks put into housing units that might not meet their level of need. And so it's forced us to create a very more comprehensive internal transfer process. Currently, we're using the DLA 20 to assess level of care, but we're looking for another tool. They're trying to develop another tool in-house that will get us to what we need in terms of getting folks assigned and the appropriate services when they're in housing. There's three different things that can happen when someone's been in housing that might change their level of care. So you have folks that are aging in place whose medical needs become more pronounced and they need a higher level of care. A lot of times individuals can grow into families, and so it might necessitate a move to our family support services program. And then, of course, what we all know to be true in the healthcare field is that folks who are housed a lot of times are able to manage their health better and it can drop down to a level of service that's not quite at the ACT level. And so right now I'm going to hand it over to Lisa to sort of go into more depth around our service delivery models. And
Great. Thank you, Matt. This is Lisa Thompson. I'm the Chief Operating Officer here at the Colorado Coalition for the Homeless. So CCH supports close to 1,500 clients and families through our different case management models here. We have a really dedicated and skilled staff who provide us an incredible amount of support to our clients on a daily basis. And as Matt mentioned, they provide different levels of intensity of service and case management supports. So we primarily provide our housing supportive services through our residential services program, through our family support services, and as everyone has mentioned, through our Housing First and ACT. So in our residential services and family support services, these programs primarily are supporting our clients who are residing in our CCH properties. However, they do have some clients residing in scattered site apartments as well. But the staff-to-client ratio for this group is typically between 20 to 30 clients per staff. And on each of the properties, the site is generally supported by at least a case manager and a therapist usually. And sometimes we have 2 case managers per site. It really depends on the size of the property. But in-home therapy is generally available to all clients as it's requested. And then for our Housing First, we implement a modified assertive community treatment teams. And we currently have 5 teams across the coalition who are serving approximately 500 clients. So ACT services consist of a multidisciplinary team. It's definitely a team-based approach to care, and it's an evidence-based model of providing community mental health support. And the whole team is really working to support all of our clients versus an individual case manager or individual therapist. And in order to meet the full fidelity of the ACT model, there's a specific staffing pattern that's required, and so we are working currently towards meeting that model, but we call ourselves modified at this point because we're not totally to the true fidelity of the model. So generally a team on the ACT team would consist of case managers, therapists who may also be substance treatment specialists, peer mentors, a nurse, and when we're fully staffed, we would also have a psychiatric provider for each of the teams, and the teams are generally supported by a program manager or team lead. And the ideal client to staff ratio for these teams would be about 10 to 1. More realistically, currently it's closer to 12, 13 to 1, sometimes a little higher depending on when we have staff vacancies. But the idea of the ACT model is that all of the staff are working with all of the clients. And also that the majority of the services provided by the ACT team are occurring out in the community or ideally in the client's home, and we're really encouraging frequent home visits by the staff. And most all of the clients coming into our assertive community treatment teams are receiving a psychosocial assessment. But all of our clients in all of our housing programs, including our residential services and family support, complete a case management needs assessment, and they identify individualized case management goals that the teams are working with them on. And then, as John mentioned, all of the clients in all of our housing programs also have access to our Stout Street Health Center and all of the services that are provided there. Additionally, the case management teams are working very closely with our vocational support team, and frequently the vocational services staff are attending team meetings. They're completing job clubs and having groups on site for the residents to really help them meet their vocational goals. And so as Matt mentioned, we have sort of the current state and then the ideal state that we're always working towards. And in the ideal state, the clients would be able to move between the services based on their current need. But due to our various funding streams that require us to prioritize certain populations, and certainly due to the one home system that requires us to prioritize clients for housing based off of the specific wait list, we found it somewhat challenging to align our clinical services with our housing resources, and it's something that we're actively working on with the goal of developing this framework around a level of care that would help us to identify when a client may need to be transferred to a higher or lower level of care. That's something our teams are actively working on, and we feel really hopeful that we will attain that. Ultimately, obviously, the goal is to align our housing and clinical resources to best meet the client's needs. Additionally, many clients coming from the coordinated access system we've found, one of the challenges is that we found that they may have higher level of need when they're assigned to a certain unit. So for example, we could have a client coming out of the coordinated entry system into our residential services that has a higher client to staff ratio, and that person may certainly be needing more intense support. So to talk a little bit about our funding sources, as John mentioned, it's generally a blended mix of funding sources. We certainly leverage the supportive service dollars from our HUD grants that have that funding stream available. Typically, we find that that amount of money available is not enough, particularly to meet the intensive service model of the ACT teams. And so we are supplementing this. Generally, we try to leverage local city and state grant funds. We certainly apply for and utilize SAMHSA grants and funding, and frequently have foundation and private grant funding to help support the teams. And then in addition, the teams are able to also get reimbursement through Medicare and Medicaid for the clinical services that they are providing. So some of the primary advantages and benefits of these different models of case management, certainly clinicians based at the property can allow clients easier access to their care team or to receiving clinical services. One of the disadvantages of that we've seen, though, is that having one case manager or one therapist on the site can be somewhat isolating when they're housed away from the rest of their team. But when they're on site, they may also have a better idea about what's going on with the client, so they can respond to issues that arise more proactively. And then for ACT services, I think there's certainly an advantage to a team-based approach to care. We have found that some of the clients might identify or respond better to certain staff, and so by utilizing the team, we can certainly better engage the clients overall. And then additionally, I think that one of the benefits of the ACT team is that the team can help to support one another during challenging situations. They can work in pairs when there's a safety concern. They can go out together. That's one of the advantages, and then certainly one of the disadvantages when we have more model where the case manager is just located on the site, kind of disconnected from the rest of the team. And as Matt mentioned, the scattered site placement of clients can also allow clients to have a greater housing choice, which is extremely important. And Matt also mentioned one of the other common challenges that we see is when a client needs to relocate from the site where their team or where their case manager or their therapist is located. That can cause disruptions in their care and certainly in their housing. If they lose their housing subsidy, obviously that's problematic, and then it can also, they may lose access to that case manager who's dedicated to providing services in that building. As opposed to the ACT teams, they are generally following the client where they go. And then just real quick about safety issues, certainly there's costs associated with providing security on our properties, and when we have scattered site locations, we're not paying for that cost generally. However, many of those sites also then don't have security, which can be problematic as well. So in terms of next slide, we wanted to talk a little bit about the integration of our services and our property management. We're also currently working hard to overcome some of that natural tension that we know arises when you bring together people who are working in various roles. So certainly our property management staff is focused on the asset of our property, which is extremely important, and they are focused on making sure that the building is safe and secure for everyone, and that the operations of that building are running smoothly, rents are getting paid, and certainly the property is being taken care of by the people who live there. And the service staff obviously is more focused on working with their client in recovery and working on the healing process. And they may be more tolerant to behaviors that property management might not be used to or find problematic. So that can cause some natural tension just, with the different perspectives that folks are coming from to their roles. But one of the benefits that we have here at the Coalition is because our property management staff are employed by CCH, we know that we're all working together towards our common mission, which really, kind of binds everyone together, and we ultimately have the same goals of making sure the property is safe and keeping our clients housed. And we frequently, refer to that as, we're all in this together, we're all working towards a common mission, which I think is really important. And we've found that helping to cross-train our staff has been extremely helpful in regards to integrating our services. So our property management staff is currently being trained in mental health first aid, for example, and all of the staff across all of our programs are trained in trauma-informed care, cultural competency, which is extremely important. And additionally, we're also working currently on training our program staff on some of the fair housing laws and other requirements that our property management must follow, so that people are understanding each other's roles, which can certainly help with working together. And we know that co-location of staff can increase communication. And then most recently, we've housed one of our entire assertive community treatment teams in a building with property management staff. And we've also hired a resident service coordinator that can serve as a liaison between property management and our service staff. And that person is attending meetings both for property management and for the clinical teams.
Yep. So this is Bill Windsor. As Lisa had indicated, safety is a very important issue for us. So safety of our staff, safety of our clients and residents are all very important. Towards that end, we have established a position of the Director of Safety that oversees safety organizationally for us overall. And then on top of that, we provide individual security services at each of our properties. So at every location to where we are serving clients, we have security guards that are hired by CCH for providing added safety for that. And then we also will provide at our properties after our security when our staff is not present in partnership with the Denver Police Department and also with private security firms to provide patrols to the properties and make sure that during off hours that the properties are safe and that incidences aren't taking place. I think that's good. Next one.
So just wanted to give a highlight of one of the projects and walk through a little bit of the financing. So the Stout Street Health Center and Lofts is a project we completed about 4 years ago. It's where our flagship Healthcare for the Homeless Stout Street Health Center is located on the first 2 levels. And then we were able to build 78 units of permanent supportive housing on the upper 3 floors. When we designed the building as a way to both meet the integrated healthcare needs of those currently on the street as well as those that we've been able to move back into housing, and we were able to target then the permanent supportive housing on the upper floors to folks who might need more access to our integrated health services in a way to address that need. So in order to build this and to give an idea of how the financing came together, because we utilized both low-income housing tax credits for the lofts and new market tax credits for the health center, we needed to segregate that financing, and the way that we did it was by creating a condominium regime for the building that we were building, so that the South Street Health Center is the health center condominium, and the South Street Loft is the residential condominium on the upper floors. And that way, even though we built the building together, we were able to segregate the financing to construct it, and we operate it then through that condominium structure. To fund the health center, we used new market tax credits, which generated about $4.2 million of funding through the tax credit investment. We received a HRSA capital grant of $5 million. We were able to raise about $5 million from a capital campaign targeting foundations and businesses within the community. We took out a leveraged loan that went through the new market structure of about $3.5 million, and then raised another $375,000 through individual contributions. So a total of about $18 million to fund the construction of the health center. Then the lofts were financed through the low-income housing tax credits that generated about $12.2 million of equity. The City and County of Denver put in $1 million of home funds. The Colorado Division of Housing put in $1 million of home funds. And then we received about $800,000 through the Federal Home Loan Bank, which is an affordable housing program administered through the Federal Home Loan Bank system. And then the balance of it, about $678,000, we were able to get through a variety of contributions to support the housing development. So overall, it was about a $33.8 million development, and it allowed us then to not only construct the building, but then to set up some reserves to operate the building. And then just wanted to end with our newest development that we placed in service in June, which is the Renaissance Downtown Lofts, located just across the street from the South Street Health Center, and it provides 100 units dedicated to people involved in one of our assertive community treatment teams through the Denver Social Impact Bond. We're targeting chronically homeless individuals who are high utilizers of the city jail system, and through that on-site integrated assertive community treatment and access to the health center resources, we're able to serve a more vulnerable population by mixing the integrated health and the property management services as we described earlier.
Okay. Wow, we covered a lot of ground in 1 hour. So thank you all. We've had a number of questions come in, and so I'll just hit a few of these up front. One question is, do you receive any funding for medical or support services from others in the healthcare world, such as hospitals or insurers, because you are keeping their costs down by providing your model to this population that otherwise would go to emergency departments as primary care?
So our original funding for the support services has been to leverage existing services that we provide. And one of the things that we have found is that the benefit of doing housing development as part of a health center and doing integrated health services as part of a housing development activity is that we're able to use one to leverage the other. And so in some cases you have an entity that doesn't want to fund housing but loves health care, they'll fund the services. Others that will only fund the housing piece, but they love the fact that we're able to leverage the services. Our initial funding for services, in addition to what we were able to carve out from our original Healthcare for the Homeless grants, have been by including support services in what is now the continuum of care funding source, what previously had been either shelter plus care or the supportive housing program through HUD. And then we've also been able to, as a Medicaid expansion state, we've been able to leverage our federally qualified health center status to be able to get reimbursed for the clinical services that are provided to residents of our housing. So whether they're coming to the health center and we're getting reimbursed from Medicaid or Medicare, or we're sending a psychiatric provider, mental health counselor, or even a primary care provider to the housing, they can then get billed for those services for somebody who is Medicaid eligible.
Got it. Okay.
We are looking at trying to expand and get the health community more involved up front. It's been a long conversation, and we're hopeful that our next development, which will be this standalone respite facility, will in fact use hospital-funded systems to demonstrate the cost savings from the medical respite intervention, and hopefully through that gateway to be able to convince them that ongoing support for permanent supportive housing is beneficial to the health systems.
Excellent. Two questions that are fairly straightforward that came in. One, how long do clients remain in the property? And two, do you pay a monthly property management fee?
So the first question, it really varies. We have been able to achieve an over 90% housing stability rate for our housing developments. We have a property that just turned 21 years old, and there's still a couple of residents who moved in on day one who are still there, others who have moved on, others who have passed away. And so that turnover occurs. But we use a permanent supportive housing model that doesn't have any arbitrary time limits. And while we work with individuals to help them transition to other housing that they might feel that they would like to achieve, we don't require that they move on. In terms of the property management, we do get a fee for the property management activity. It comes out of the rent. But just like if we were paying a third-party property manager, we're able to use those funds to pay our property management group to help cover their costs.
We had a question come in. So while Bill and Lisa were talking about property management and the training there, a question came in about what kind of training materials do you use for that purpose?
Sure. So I can talk a little bit about that, and then maybe Bill can chime in. We have on staff here a trauma-informed care coordinator, and so she develops our trauma-informed care training. And then we've used outside consultation to develop our cultural competency and inclusion trainings. And then certainly the mental health first aid training is a standard training that people can attend in the community. And then Bill, maybe you could talk about some of the housing.
Sure. So in addition to that, the Director of Safety provides trainings overall to the staff. For the medical staff, they will be training in regards to the safe use of sharps and the safe disposal of sharps. We provide CPR training across the board. The director also provides with all the different groups situational awareness training, so that when they're working with the clients, they are staying aware of the positioning of where they're meeting with the clients. We always like them to be aware of where exiting can be available if needed, and other type of situational awareness that just brings an overall sense of safety to the staff.
Another question that we got in when talking about the size of units. Can CCH house larger families that require more than 2 bedrooms in their unit?
We can and we do. So we have a few properties that have larger units and are dedicated towards families. In the cases of those properties, we will also have outdoor use that are designed to be friendly for children and indoor uses that are friendly for children. For example, when we build our community rooms and our family projects, we will have a subsection of the community rooms as a children's room where children can be there during the day and have indoor play and reading areas, as well as having the outdoor areas. It's more difficult for us to deliver family housing because many of our grant sources are based on a maximum amount of funding per unit. And as you can imagine, a 3-bedroom unit is substantially more expensive to build than a 1-bedroom unit. So it becomes difficult sometimes to be able to meet our budgets on our family projects.
Yeah, and additionally, CCH certainly houses larger families with our scattered site housing subsidies. We have, approximately a little more than $5 million targeted continuum of care funding that we use for families here at the coalition. So we certainly will serve families of any size that get referred to our systems here.
Got it. Financing question. When you apply for a building loan, do you have to provide collateral for the loan?
So John outlined pretty well about how we finance our projects with multiple sources. However, during the development phase, let's say for the acquisition of a new property, we often will use a property that we own free and clear as collateral for either a bridge loan or a temporary acquisition loan, which is then taken out by the financing for the mixed-use financing for the project that John related to. In regards to the construction loan, during construction, yes, they do require collateral, and the property itself is offered as the collateral for the construction loan.
Excellent. Question here, and even a math problem, perhaps. So if an apartment costs $600 to $700 a month, how much would you say an apartment would cost with supportive services included?
So we always have debates over that with funders about how much it should cost. And so as Lisa talked about the more intensive assertive community treatment services, we find that typically runs about $750 to $1,000 per client. And so you can see that can range even higher than the cost of operating a particular apartment. When I mentioned the $600 to $700, that's where you have a property that's free and clear, that is no long-term debt on the property. When you do have that long-term debt, that adds anywhere from another $100 to $200 a month of debt service that then means that the rents need to cover those additional costs. So as Bill had indicated in one of his slides, trying to get as much capital up front to reduce the long-term debt is beneficial in making the property more affordable over the long run.
Next question about resident services coordinator. Is this position funded directly, or is it out of a pool of services funding from multiple sources?
I think currently it's out of a pool of resources. Initially, I believe that the position was funded through our property management, but I think we're looking at splitting that funding between both the services side of things and the property management side.
Got it. We've got, and next question actually reminds me of, I want to take us back a little bit. And Bill, you had started to talk about some of the design pieces to our units. And one of the questions that came in is, what have you learned over time on the development, design, materials, and amenities of housing? And I know some of that was here on this pro tip slide that we glossed over fairly quickly in the interest of time. But now that we have a few minutes, let's go back and I want to hear a little bit more from you about what that design piece is and what those amenities look like.
I'm happy to do that. On the amenities side, We find it absolutely necessary to have laundry services within each building. So we will contract with an outside laundry vendor for providing the equipment that we need designed to provide enough washers and dryers in our laundry facilities to meet the needs of the entire population of the building. Another important consideration, is we've talked a little bit about our community rooms. So our community rooms serve many needs. The community rooms are there primarily as a place for the residents to gather and to have a lounge outside of their units. Our community rooms are very often coupled with an outdoor deck area that they can also have the outdoor deck to get out there during nicer weather. The community rooms also serve a function for both our property management teams and our project and our program management teams to be able to meet with the residents and provide trainings to the residents, or to, from time to time, just to provide a service such as on a major holiday, such as Thanksgiving and Christmas. Our property management group will go ahead and have a large Christmas party or Thanksgiving party within the community rooms to make sure that everybody has an opportunity to enjoy their turkey and to enjoy the celebration of the holidays as well. Lastly, it serves an additional purpose for us for keeping that link to the local community so that we will also allow the local neighborhood groups to use our larger space from time to time when they want to hold a neighborhood meeting. And again, that just helps us to maintain that link to the community, that we are very much a project that is part of the community that's there. Some lessons learned in regards to design development for material use. One of the first things that we've learned is that for the hardware on the property, we want to use deadbolts instead of doors that can automatically lock. Our earlier projects used the combination locking system with the finger lock with the door handle, and we were just having way too many people who were locking themselves out. They closed their door, they went out to put the garbage out, and now they can't get back into their units. And that would often mean after-hour calls to where we would have to have staff respond after hours for letting them back into the units. With the deadbolts, they have to have the key with them when they exit the room in order to lock that door. So that greatly reduces that need. Fire suppression is something that we have been learning to use. When we're talking about fire suppression, we're not referring to the overall sprinkler system. All of our properties are fully sprinkled. But one of our bigger potential damaging events that could happen is if a resident is not paying attention to their cooking and or walks away from the kitchen area while their foods are cooking. We have had a number of instances to where the sprinklers went off in that unit and created flooding within the unit. So what we are adding now to our properties is a link to the stove power source and to our to the smoke detectors. And so when the smoke detectors go off, the stove is automatically shut off. And we also utilize very small canisters of dry fire extinguisher material. If a fire were to break out, if someone's cooking and say they have a oil fire while they're cooking, we have these miniature cans that act as fire suppression to put that fire out on an immediate basis. Let's see what we have up here. So,
and just real quick, Bill, one other addition to that is that's one of the important roles that the case management program staff play is in holding life skills classes in the properties for the residents to kind of teach them general life skills, safety, cooking, that sort of thing, to help mitigate some of these issues?
So one of the items that I want to mention is ceiling height. That one was really driven by John when he first started developing. Since we often cannot make our units quite as large as market rate units, we try to be competitive in that and get close. We find that by having higher ceilings, that the rooms read as much more comfortable and not being too small or encroaching to the residents that are in there. Another purpose that it does, and another design process, to where we can, we try to have the residential units be on the second floor upward in order to create a barrier between the streets and the residential rooms. When we first house people for the first time coming in, many of the residents have friendships that they have developed with the community, with the homeless community that's out there, and they, very often, from the goodness of their hearts, they want to bring in that community into the unit. We found that when the units are on the ground floor, there's too easy an opportunity to let folks come into the building through the residential windows, and by having that barrier, it does two purposes. We take out the ability for communications, or especially for folks to try to get into our buildings, which are access controlled through the windows, but it also provides a nicer environment for the residents as it separates traffic noise, further separates traffic noise from the residential units, so that the residential units have a quiet, enjoyable environment.
One of the things I remember that we were talking about when we visited in December was how you worked with local zoning or local requirements for parking and the parking reduction. And I know that we hit on this briefly before, but I felt like the parking piece can be a trip up for local projects. Did you want to talk just a little bit more about how you negotiated some of those pieces on your local requirements?
Yes. So with the parking, we do have to we are required to meet the municipal code of the number of parking units per unit. However, the reality is that our residents, and this is provable through the census demographics, at the income level that our residents have, they either have the average number of cars per family is 0.5 at 30% AMI or below. So we can demonstrate through the census that our residents really do not have a large number, do not have automobiles in general, and so we can reduce the required parking spaces by making an appeal to the zoning committee to allow us a reduction in the parking, which also then helps us to capture the land use for building more units rather than wasting a lot of space and dollars on developing parking spaces that are not being utilized.
That's helpful, thank you. And these are the kinds of things that I just don't think people think about going into it. And so the details there were so helpful in terms of, again, a pro tip that you've obviously had to do a number of times. Last question on this slide too, the small area fair market rent. We touched on that earlier, but you had talked to us at length about how you can calculate rents or fair market rents and the whole bit, and how you can get a more favorable rent by negotiating a small area fair market rent. Can you tell us a little bit about that?
So, the fair market rents are the HUD standard, and so with a Section 8 voucher or a continual care voucher that limits the amount of rent to the fair market rent, having a higher fair market rent is beneficial in that it provides more funding that can then be used to enhance amenities and security and maintenance on the property. And so when you're able to focus on an area that may have a higher market rate rent than the area, the metropolitan area. Being able to get the fair market rent targeted to that geographic area allows a little bit more flexibility than if you were stuck with the broader, sometimes lower fair market rent.
Helpful. So we'll come back to bigger questions. One thing that I know we had questions about and other folks have inquired about as well is the qualified allocation plan, or the QAP with the state. How does the QAP factor into the work that you're doing here?
So the qualified allocation plan is required to be approved by the Housing Finance Authority that's allocating the low-income housing tax credits on an annual basis. It sets the priority for allocation of what is limited resources and in many communities oversubscribed. And the QAP needs to be approved by the state's governor. Over time, we've had a lot of advocacy with the state Housing Finance Authority, trying to get them to target and prioritize more permanent supportive housing for homeless populations. Sometimes they have done that. Sometimes they have not been as supportive of that. Our current governor, John Hickenblooper, who was the prior mayor of Denver, who worked hard to address, to create a 10-year plan to end homelessness in Denver and took that to the state, was a strong advocate of targeting tax credits to fund permanent supportive housing. And so with that ally in the governorship, we've been able to and our partners across the state have been able to develop more permanent supportive housing than might otherwise have been the case. In some states like California, they provide priorities so that the points in the allocation process are enhanced for projects targeting the homeless, those who are targeting permanent supportive housing or even transitional housing. So you should really understand what the qualified allocation plan is in your state, and to the extent that it's not conducive to supporting a project that you want to develop, advocate that they give favorable treatment to that in the allocation plan.
Then I will add that during the development process, when you are doing your application for the tax credits, you want to make sure that you are in your narrative that you are addressing the QAP and show how the project you are proposing does meet the requirements, meets and exceeds the requirements of the QAP.
Okay, so in our last couple of minutes, we'll come up to really big picture. What's your vision for where you think the funding for housing, the concept of housing as healthcare, where do you see this going in the next 5 years?
So, it's always a moving target. We see some progress only to see some setbacks, and it really varies from community to community. As I've traveled across the country and talked to folks who have been doing this work, we're fighting in Denver right now escalating land costs, escalating construction costs. And so even though we've been successful in getting the city and the state to put more resources into both the upfront development of housing and providing housing vouchers, what we're seeing is that those dollars don't go as far. And so while we in the past have been able to easily do a 100-unit project, our most recent one is scaled back to 60 units because the available financing only covers that amount. So as we advocate at the national level for more money into the National Affordable Housing Trust, as we advocate for continued funding for permanent supportive housing within the HUD Continuum of Care programs, and as we advocate for expanded low-income housing tax credit allocations, we need to make sure that that keeps pace with the cost of construction and the cost of acquisition in local communities.
We also very strongly advocated with the city of Denver, as well as other affordable housing organizations, about the need to enhance the funding that they have available for affordable housing. And so through that advocacy, the city did move forward with a tax measure to bring in additional dollars to help fund affordable housing within the city and county of Denver.
Lisa, Matt, any last thoughts before we close up?
Oh, I guess I was just going to say, for the future, I really hope to see the healthcare system come to the table to help to fund the affordable housing for many of the clients that we are seeing in our programs, and I'd like to see that partnership grow over time.
Yeah, and just thanks to the council for putting this together. I think the progress, that we've made just discussing housing as healthcare and moving forward with that mindset is only going to open up avenues for creating affordable housing in the future.
Yep, and I think I will add as my last statement that these projects only occur by your will to make them occur. We constantly get no's, and we hear no as a maybe or find some other path to making that no into something that works. But you do have to constantly, willfully drive forward to bring these properties online.
Fantastic. Again, we have covered so much in an hour and a half. John, Lisa, Bill, Matt, you guys are fantastic. Thanks so much for coming together, for having this discussion, sharing your expertise and the experience that you've put together in Denver with all of us. Hoping that this answers some of the frequently asked questions that people have out in the field. We've had a lot of interest in not only this topic, but in this specific paper and in this specific webinar. Again, I would point folks to the two resources that are on your screen, one being an enterprise report on the Stout Street Health Center, and the other being our policy brief. All of these materials will be archived on our website. Anyone who registered for it will get the video recording and the links directly. And at the close of this webinar, there's a survey that evaluates it. Please, if you can fill that out, that helps us deliver really high-quality training opportunities for our community. So with that, I will close out our webinar. Thank everybody for coming, and please share this conversation and the lessons that you've learned with your friends, with your community partners, and go out there and make this work, because what Bill said is right. It's about the will to make it happen, and cobble together the resources that you have at hand, and we should see some real growth in this area in the coming years. So thank you again, and we'll